heard the term pace yourself, right? Well, whether it's about running, working hard, or some other challenge, this presenter is all about getting the right pacing for children's hearts. Yet he hardly paced himself when it came to studies. Dr. Rhee majored in neuroscience and then apparently needed more challenges, so he shifted to cardiac electrophysiology. He attended the University of Pittsburgh School of Medicine, did a residency at St. Louis Children's Hospital, Washington University School of Medicine, and a fellowship at Children's Hospital Boston. By way of St. Louis, he ended up at St. Joe's and joined the PCH family when the two hospitals joined forces in 2011. He is the proud dad of two teenage girls and the product of two teachers. He's here to teach us a bit about how our heart works or doesn't, and when kids need to get the best in tech to get the right beat going. See if you can follow along because he is pushing boundaries. Dr. Rhee, take it away.
Okay, so for the next 5 minutes or so, I'm going to tell you a little story about pacemakers. So how would you like your heart to beat? Like a well-organized school of fish where every cell is in line doing what they're supposed to, or having sort of an amorphous blob where they more or less get where they're going, but not really in the most efficient manner? If you look down below, you can see the conduction system of the heart. It's almost like a series of nerves. The heart impulse begins at the top of the right atrium, conducts down to the center where that AV node is, and then it follows a series of nerves, or what we call bundle branches, to the right and left ventricles. And when everything is good and everything's firing in tune, heart beats like this. Both walls moving, everything's good. Now there's a condition called heart block, and this can be acquired after surgery, it can be congenital, and that results in a blockage right in that middle way station where the impulses no longer conduct from the top to the bottom. And how do we treat this nowadays? Well, we kind of do the bypass with the pacemaker. So pacemakers come in 1, 2, 3 lead varieties. The dual chamber pacemaker, or 2 lead, is our most common pacing system. It has 1 lead up in the right atrium, which listens to the normal heart rate. It has 1 lead below down in the right ventricle, and it reconnects the top to the bottom like the normal conduction system does. But it's not quite perfect. What it does is it paces the lower chamber, but it really doesn't engage all of those nerves and all of those conduction elements. And what you can see on the ultrasound of people that are conventionally paced is instead of the heart going like this, it kind of does this. It wobbles. So while one side of the heart is squeezing, the other side of the heart's relaxing, and vice versa. And again, it works, but it's not optimal. So wouldn't it be nice, in the words of the immortal physician Dr. Brian Wilson from the Beach Boys, wouldn't it be nice if we could take advantage of the normal conduction system? So in the next cartoon down below, you can see how it's done now. This is a relatively new technique, been around for about 3 years. And what you do is, with a specially designed pacing lead, you tediously maneuver it onto that center nerve, or what we call the bundle of His, not his, His. And we insert that electrode there, and if you get it just right and just perfect, you can actually bypass the side of block, engage the conduction elements, and use the residual nerves that are left in the heart that gives you a much more synchronous beat. And on the next picture, you can see that it really makes a difference. If you look at the EKGs, it doesn't take an electrophysiologist to tell that, thin is in, skinny is better. And the EKG to the right looks a lot better than the EKG to the left. And when you look at the ultrasounds, instead of getting this, you get this. And in the little graphs down there, you can actually see that it makes a survival difference. There are so few interventions that we actually have that improve all-cause mortality. Some of our things are designed to reduce symptoms, palliation, but this actually improves all-cause survival and has been shown to reduce major adverse cardiac complications. So why don't we all do it, okay? It's hard, it's tedious. If you look on the next set of pictures, these are some micrographs of a patient that underwent His bundle pacing and then died of an infection a few years later, and he was kind enough to donate his heart for study. And you can see there that on the right-hand panel, those little white circles are where the pacemaker leads or the screw elements were. And around that is all this blue stuff. The blue stuff, blue is bad. And that's what we learned in medical school. Blue is fibrosis. Fibrosis is thick, connective, non-conductive tissue that sort of stabilizes the lead in place, but really makes things harder. It requires more energy, more electricity, shorter battery life. And if we could inhibit fibrosis, or even better, recruit or engage some of these conduction elements preferentially, we would have the perfect pacing system. We wouldn't have to worry about high thresholds, early battery depletion, and location would be less critical. So even if you got it in the neighborhood, eventually you would recruit those conduction elements. So with the help of Dr. Medinika down at ASU, who's a bioengineer, he's come up with a very unique method of plating these things called GNRs, or gold nanorod. These are tiny little particles that allow the cells to organize and form a organized matrix. You can see that on the next panel, cells couple, they beat together, they beat as one. Our plan will be to harvest these cells preferentially off the septum. You can see that in the fluorescent micrograph there, the green elements are conduction tissue, and we intend to plate them on these checkerboards to see if our gram-negative rod our gold nanorod matrix preferentially attracts and stabilizes and promotes connection of these cardiac elements. This is a complicated project with great potential. The pacing demand in the United States, the world market is estimated at over $2 billion. This has an important role in our kids, but also has great scalability to the adult world as well. And on the last set of figures there is our timeline. We estimate we can get it done in a year.
Dr. Rhee, thank you very much, and I like that you worked the Beach Boys into your presentation. Very, very nice. So let me ask you a few questions here. How many kids need pacing for their hearts?
It's variable, but somewhere between 1% to 3% of all cardiac operations result in the need of a pacemaker. Currently, we follow about 700 children at the Phoenix Children's Hospital, and we're one of the larger programs, but many of the programs around the country have similar volumes.
After this project is completed, what would be the next steps?
The next steps will be to place this onto an actual experimental pacing electrode. Dr. Nika has worked out a way to bind the gold nanorods to the titanium tip screw, and we hope to test that in vitro and a small animal model.
So by conducting this work, what specifically will it do to support PCH and the kids that the hospital serves?
Believe it or not, there are no pediatric devices. There are no pacemakers, no pacemaking leads approved for use in children. And there's a reason for that. It's all regulatory. The companies have no incentive to develop a device for a market that is so small, but they listen to us. And if we can come up with new and innovative things, they can extrapolate that and transmit that to their adult patients, thus satisfying the regulatory and market needs. So I think we can lead the way.
Well, that's what I was going to ask you. It sort of leads into the next question I was thinking about. With getting this to work for kids, does it have implications for adults and or longer-term prognosis?
Yeah, for us, it'll be a niche kind of thing. We spend the time, we do things very tediously because we know that the first lead that a child gets will not be the last one. So we want every lead to be as perfect and last as long as they can. In the adult world, your first lead is often your last lead, and if it lasts 15 years, that's good enough. But we play for longer odds than that.
Are you pioneering some things here with this initiative?
The ability to do this with a non-pharmacologic, non-steroid matrix is the game changer. Gold is an inert metal. It's biocompatible, and from a regulatory standpoint, this would not be a completely new redesign or resubmission. This would be a modification of an existing design, so we imagine it could come to market fairly quickly if we can just demonstrate that the tip works and it's friendly to the cells that we want.
And just in closing here, why, just on a personal level, why are you so passionate about this?
Nobody likes pacemakers. They're a necessary evil. It limits the child, limits contact sports, batteries changing every 10 years. If we can get something that is as close to their normal conduction as possible, then that's what the reward is. Pacemakers are never going to be a cure, but we want it to be as close as possible.
Dr. Rhee, thank you so much. Great job.
Thank you.